Welcome to Ed's Cosmetic Surgery. Our new clinic facility was built to provide the ultimate in efficiency and safety for our patients. As you enter our center, you will note that all details have been designed with soothing colors and comfortable furnishings. Our patient-friendly staff greets all patients with one goal in mind: your comfort.
I'm Stevie. It's nice to meet you. Welcome to our practice.
You will find our consultation room to be very comfortable and soothing. We believe in giving each patient as much time as they wish to ensure that all questions are answered and that they are totally comfortable with the information they have received. Our skincare section is equipped with the most up-to-date, state-of-the-art laser and skincare systems to treat virtually all areas of concern, including tattoo removal, hair removal, wrinkle removal, brown spot removal, and many other issues. For minor procedures which can be performed under local anesthesia with minimal oral sedation, our fully equipped minor surgery suite is a cost-effective, efficient alternative to using our accredited surgery center. On the day of surgery, our patients are admitted to our holding room where IVs are started, preoperative medications are given, and a certified anesthesia provider evaluates each patient, and we plan and mark for each procedure. Family members are present until patients are taken to the surgery suite. Our state-of-the-art surgery suite is equipped with the same equipment and monitors found in any modern hospital or surgery center. Anesthesia is administered only by certified anesthesia providers. Highly experienced operating room nurses and certified surgical technologists assist with each procedure. Following the completion of the procedure, patients are taken to the recovery room where an experienced nurse monitors them until recovery from anesthesia is complete. Usually within an hour or so after the completion of a procedure, patients are allowed to leave with their family members. As you can see, our facility is designed with the utmost in patient safety and comfort in mind. We think you will understand why we are the busiest cosmetic surgical practice in the tri-state and look forward to working with you to address your concerns. Hello, I'm Dr. Eds. I want to welcome you to my practice. The purpose of this video is really twofold. First, it's educational. Secondly, it fulfills a medical legal requirement that everybody undergoing a procedure have what's called informed consent. The first part of it, the educational part of it, is especially important. I think some people come in having done a great deal of research, looking on the internet, talking to friends and so forth, and they're very well educated about the procedure, while others really are not quite as well versed in the ins and outs of the procedure. Because this is purely an elective surgery, I think it's very important for every patient to understand that this is not something that saves your life. It's something you're doing to improve your self-image or your body image or your appearance, and it's something that you don't really have to do. So I think it is especially important in this case that you understand all of the risk and complications and the ins and outs of the procedure. As you go through this video, you will have in your lap a clipboard that's been given to you that will have a sheet of paper on it. And this sheet of paper is a checklist. And actually it's more of an initial list. This has on the sheet, in the order that I'll be talking about things, each individual item. What I want you to do as you listen to this video, and this is very, very important, is as you listen to each item that's discussed, if you understand what you've heard and you're comfortable with it, just put your initials there. Don't check it, put your initials. That way I'll know that you have heard it and understand it and you don't have any questions. If you run across an item in the video that you don't quite understand, what I want you to do then is to leave it blank, go down to the bottom of the form, fill out your question. You can do it in shorthand or any way you want to, but I want to know the things that were not fully explained or things you don't understand that you want some more information on. That's a very important part of the informed consent process. As a patient, you are entitled to know the risk and complications that are potential to a procedure, as well as the alternatives to that procedure for what you're considering. So this part's very important, and as we go along, it's important that you follow along. If at any point you want more information, you can rewind the video, you can go back and review it, but make sure that each individual item is something that you understand as you go through the video. I've been doing breast surgery for about 30 years now at the date of this video, and now it's late November of 2015. I started doing cosmetic breast surgery in very early 1986. And since then, I've done well over 4,000 patients for cosmetic breast surgery. It is the largest portion of my practice. It has grown over the years to the point that I have the largest breast practice in the tri-state. Fortunately for me, 98% of the patients that come to me for breast surgery are from other patients. Hopefully happy patients, or I guess they wouldn't refer you to me. But I don't do what I consider to be cheesy billboards or radio jingles in general, and I tend to rely on patient referral and hopefully happy patients to build my practice. The big question sometimes is, why choose cosmetic breast surgery, and in particular, why choose breast augmentation? And that's a question that's considered by about 300,000 women every year in the United States, because that's the number of women who have breast surgery. And the answer can be a lot of different things. It can be lack of development. It can be loss of tissue after childbirth. It can be a congenital or a developmental asymmetry, or where the breasts are not or don't look very equal side to side. And I think one thing that's an important point here is that breasts are not supposed to be twins. They're sisters. Now, hopefully the sisters are close together. And if your sisters are really different in terms of size or shape, my goal, of course, is to get them to where you're totally happy. But the realistic goal is to get them close enough together in size and shape that it's not noticeable in clothing or out of clothing to where you're happy with the surgery. Other reasons are loss of tissue after childbirth, a lack of proportion. A lot of people are built so the top part of their body is in a different proportion than the bottom part. More often than not, the bottom part's a little bit bigger than the top part. So trying to balance the body out and gain some proportionality is really important. Obviously, confidence is an important thing, but what it always boils down to really is body image. How you feel about yourself. How do you feel your body is perceived by other people? And while I know that maybe what other people think about your body is important to you, I think it's very, very important to understand that this is a procedure that you should consider for yourself and not because someone is pushing you into it. It is really unusual, and over 200 women a year for cosmetic breast procedures, it is very unusual for me to run into a situation where a woman is being pushed to have breast surgery because of their boyfriend or their spouse or their fiance or whatever. So these are just basic things to understand and to get us started. Your consultation is really important. And this video is a very important part of it because it will review a lot of the things you need to know in considering breast surgery. At the end of the video, you'll be in the consultation room, and I'll review the form that you filled out, and I will make absolutely sure that every question you have has been answered to your satisfaction. I don't want you walking out of this office with any questions or any concerns that have not been addressed. However, if you get home and in a week or a month or whatever you have a question, please don't hesitate to call back. We'll answer your questions. We do that all the time, and we want to make sure you're totally comfortable. So when we get into the consultation room, there are a lot of decisions that we make. There are decisions that are important to make you happy. One of the most common decisions is, what size do you want to be? And that really depends on what your preference is. It depends on your physical examination. It depends on whether you want to look more natural or more fake. And so the process is that for every patient, number one, I ask every patient what size they would wear in an unpadded bra. Then I want to know what size you want to be in terms of cup size. And then we look at several things in the exam room. Number one, we look at the shoulder width, then the rib cage width, how far apart the breasts are, the shape of the breastbone, whether there's any droopiness there, how the breasts play into the rest of the body. All those things are very important. But really one of the most important things to think about is what's the width of the breast tissue you have. So what we do in the exam room is take a measurement of the width of your breast tissue, and that's called the base width. And here's why that's important. Let's say, just for an example, your breasts are that big around right now, and somebody puts an implant in there that's that big around. Well, obviously, what you run into there is the edge of the implant then protrudes out past the edge of your natural tissue. That's one reason you can get a really fake, stuck-on look. And that's not what most people want. Some people want to look fake, but the majority of the people want a size and shape they like, but to look reasonably natural. My personal preference is a breast that looks like it ought to be there, and not too big for a frame, too small for a frame, or have an unusual shape, but look like not something that Dr. Ed's put on your body, but something that just developed there and looks really good. That's my personal preference. So once we do those measurements, do the examinations, and I know what you want because you've told me cup size what you want, and I think another note on that is cup size a lot of times depends on where you buy your bra. The issue there is, for example, if you buy your bras at Victoria's Secret, you may know that they upsize the letters on their bras. I don't know whether it's because they think it makes women feel better about themselves or what. They make really cute bras, and I'm all for Victoria's Secret. But one thing that I know is you cannot go on what they say that your cup size is because it's just simply not accurate in most cases. So what we do then after the examination is we use sizers, which are little temporary implants that we put in a bra that's unpadded on you, and then we put a tank top on. And we ask you to bring in, for your consultation, a tight-fitting tank top or other tight form-fitting top so that you can actually get a visual on the size. Then once you see the size, then that really helps put me closer to the bullseye in terms of making you happy. And at the end of the day, this is not about me, it's about you, and it's about you being happy. Now the next consideration after we decide on the size is implant choice. And this is a really important consideration. As of about 6.5 years ago from the date of this video, the FDA released a new implant that was called a cohesive gel implant. I use the implant that's cohesive gel that's called a memory gel implant. The implants that I use, no matter what the type you choose, is a smooth round implant because the great majority of the implants I place go under the muscle of the chest wall, and I think the smooth round implants give the most natural look and make people the most happy overall. The memory gel implant, as I said, has only been on the market for a few years. From about 6.5 years ago until right now, the implant has gone from essentially a new implant to 80% of all the implants that women choose are a memory gel implant. And there are several reasons for that. Number one, they feel comfortable with it because the government did significant studies on the implant to determine it was safe. Over 15,000 women were studied with the implant. Those studies went on for several years. The government decided they were safe. They put them on the market. And so in the time since they've been on the market, there have been many, many multiples of 15,000 women who have gotten those implants. And to this date, there's not yet been a single report of a medical issue related to these gel implants. Now, in the exam room, you'll be able to see and feel and play with the memory gel implant, which is this implant. It is a soft implant that has the consistency of a normal breast. It ripples and wrinkles the least and gives people the most natural look and feel. The implant is a little bit more expensive than the saline implant. And the way I ask patients to look at this is, number one, it's an investment in yourself in a way. And so the question gets to be, is it worth $40 per year for every year you have your implants to have the most natural looking and feeling breast that you can have, which is from this implant? This implant is most beneficial for those women with smaller breasts. The less tissue you have over the top of an implant, the more you can feel irregularities in the implant, rippling and wrinkling and so forth. So smaller breasted women really do much better with the gel implant. Another advantage to this implant is that there is a 10-year extended warranty on this implant for failure of the implant, and that coverage is included in the price of the implant. Now, there's other optional coverage for other complications that we'll talk to you about, and you'll get some information on, but that's an additional expense should patients choose it, and I don't have a lot of patients choose that really. Now, the other option is saline. Now, the saline implant's been around for 40 years or more. It's an implant that's been used for a long, long time. The saline implant is an implant that's filled simply with IV fluid. It has certainly more rippling and wrinkling. I don't know if you can see that here, but certainly in the exam room or in the consult room, when you're able to touch these implants and feel the difference, you'll feel the major difference in the implants. There's also the tendency for the implant to slosh more. It has more of a water bag feel, which shouldn't be surprising because that's what it is. It's a water bag. With that being said, I will say that it certainly has a little bit less natural look and feel than the gel implant. But it is a very suitable implant for those patients who have medium to larger breasts. By that I mean full B or larger. And the reason is, if there's enough tissue over the top of the implant to camouflage that rippling and wrinkling feel of the implant, then you can get just about the same feel with this implant as you can with the gel. So the other thing that's important that I want you to understand is, I don't make any more on either implant at the bottom line. The gel implant costs me more to buy. I pass that difference through to the patient, but I don't mark it up. I want every patient to decide on their own which implant they choose, and at the end of the day, the final decision is the patient. But I ask patients to understand that what you're choosing, when you choose one over the other, is you're choosing, in a lot of cases, how your breast will look and feel for the next 20 or 25 years. The implants are a lot better than they used to be, and we know now that probably the implants last 20 or 25 years. And so that's how I derive that $40 a year extra per for the gel implant. But you're going to choose, when you choose an implant, hopefully if it lasts an average length of time, then you're going to be choosing how your breasts will look and feel for the next 20 or 25 years. Now, the next important decision is pocket choice. By pocket, I mean, where is the implant placed? What pocket is it placed in? The most common place for implant placement in the United States, and I think around the world, is beneath the muscle of the chest wall. And the reason is it has the lowest rate of complications. In fact, probably 80% of the implants are placed under the muscle. In my practice, it's probably a little bit higher than that. The pocket under the muscle is good for most patients. Not all patients, but most patients. There are not a lot of downsides to placing an implant under the muscle. One small downside is muscle movement. When the implant's under the muscle of the chest wall and you don't have any clothes on, and you flex your chest muscles, the pectoralis muscle, the major muscle of the chest wall, will press on that implant and move it up, so the implants will bob. This is not an issue for most people, as long as they understand that up front. If you go to the gym and you have on workout clothes, it's not noticeable to other people. So that's really one of the downsides to the submuscular placement of the implant. The other pocket that's used is above the muscle. That pocket is very useful to some patients, some categories of patients. And so when you weigh this out, and you have to weigh the potential increased maybe complication rate versus the advantages, then there are a couple of groups of patients that I find really do better with the implants on top of the muscle. Number one, it's really better for those patients who are heavy. And by heavy, I mean, of course, obese. The problem there is if you place an implant under the muscle in a patient who's obese, with a larger implant, the implant's blunted. You don't really get definition. You don't get a very nice breast shape. And so in obese patients, I will usually recommend fairly strongly that the implants be placed on top of the muscle to be able to get the definition and the look of a pretty breast. The other group of patients that does really better with the implant on top of the muscle and under the gland are those with what's called a tuberous breast deformity or tubular breast deformity. In those cases, it's really required that through one maneuver or another that the implant stretch out that tubular shape into a more rounded shape to get a more normal look. And so those patients really require placement above the muscle and under the gland. There's a requirement that if you place an implant on top of the muscle, that there be adequate tissue thickness to cover the implant. So this is not by any means a good choice for those patients who are really thin and have minimal breast tissue. There's obviously no muscle movement because the implant sits on top of the muscle. And for all these reasons, out of my practice, out of over 200 women a year, I probably place implants on top of the muscle in maybe 10 patients. So it's a pretty small percentage overall. The next choice that you make and we make together is incision site. Where do we place the incision to put your implants in? The most common incision nationally, and by far the most common incision in my practice, is an incision that's just above the breast fold, just above the crease, under the breast. Now, that incision has the advantage of going straight from skin through what's called the subcutaneous tissue, directly under the muscle to create the pocket. And you totally bypass the breast tissue. You're not cutting through nerves or the glands, the ducts to the glands, and so forth, that you would going through an incision around the nipple. So most of my patients choose the inframammary fold incision, and because I've developed such a large practice with so many women out there with that incision, it must make most women pretty happy overall. Some patients choose the periareolar incision, or an incision that goes from about 3 o'clock to 9 o'clock in the lower part, right around the areola, and that's not a bad incision, but it requires that the incision be carried down through the ducts that go to the nipple, through the gland, then down to the muscle, then go under the muscle and put the implant in. So I use that incision on request. I also use it for breast lifts and other things that we'll talk about in a little while. The third incision that I have used, and I really prefer not to, is the armpit incision. Please keep in mind that no matter where you put a 1-inch incision, the quality of the scar is going to be about the same. In terms of cosmesis, in terms of how it looks, if you're standing in front of a mirror, nude, and your arms are down to your side, and you have the incision, the routine location that patients choose just above the fold, that incision is not seen. It's hidden in the fold. If you lift the breast up and look at it, or if you're lying down and your husband looks at it, you can see a line there. If you're standing in front of the mirror and you've had the incision around the nipple, that's a little bit easier to see. If you are at the beach or you have your arms up, then the incision in the armpit is a little bit easier to see. None of them are cosmetically better than another, and I frankly don't think that from a cosmetic standpoint it makes much difference. At this point, I think it's really important to talk about the downsides. I think people come in thinking about breast augmentation, primarily thinking about the upsides. They want to think about how they're going to look to themselves, to their mates. They want to think about how they look in bras and bathing suits and out of clothing. So they're thinking about the upside and getting a breast augmentation, but I think that it's really important that you understand the downsides, the risk and complications. And in fact, that's a very important part of the informed consent process. I will tell you that for all the reasons that people have revision surgery to the breast, and that'll include all the things that we're going to talk about in just a minute. The overall national average, depending on which study you look at, the revision rate nationally is about 10%. So there's no perfect world. There's not a situation where you can go to any doctor, no matter how many that person does in a year, and feel that you're not going to have any complications, that you have no risk. That's not reality. That's not the real world. Fortunately, the percentages of the complications are quite low. So I'm going to go through the complications with you now, and this is where it really gets important that you understand the complications and risk as you check off or you initial each spot on this informed consent sheet. The most common complication with breast augmentation is a hard breast. It's called a capsular contracture, and it is simply a cocoon of scar that forms all the way around the implant, and it can be thicker or less thick. But as that scar contracts on the implant, it makes the implant feel really hard. There are different grades of capsules. Low-grade capsules may mean that one breast is a tiny bit more firm than the other breast, and in those cases, they're not worth doing anything with. As the breast gets harder and it looks a lot different than the other side, and usually it's on one side for whatever reason, not always, sometimes they're on both sides. Or if it starts becoming painful, then it needs to be treated and can lead to more surgery. But the percentage of people having capsular contracture overall I think is 3 to 4%. Now you can read different numbers. If you go on the computer and you read about it, there are different numbers. But in my practice, it runs about 3%. So I see about 6 patients every year who have a capsular contracture. Of those 6 patients, half of those soften up on their own with some medication and time and massage and good luck. So out of all the ones that I do, there are about 3 patients a year that have a capsular contracture that will not respond to time and medication and massage. And I take about that number of patients back to surgery every year to take that scar out and do some other maneuvers to try to prevent the scar from coming back and end up with a soft breast and a happy patient. The infection rate nationally is about 1%. It's really unusual to have any sort of exotic bacteria grow in the breast, although occasionally there's some fairly exotic things there. But most commonly they're skin contaminant type bacteria. If there's an early infection, we try really hard to treat that with medication to try to clear it. Unfortunately, for a small percentage of patients, the infection is enough that there gets to be pus around an implant, which is very difficult to clear with just antibiotics. And sadly, and rarely, occasionally an implant has to be removed and left out for 3 months to make sure the infection is cleared and then a new implant placed. That doesn't happen often in our practice, but it does occasionally happen. The risk of a collection of blood forming in the pocket, and that's called a hematoma, is also about 1%. Most of the hematomas that form occur in the first 24 hours. Now, I'm not going to let any patient leave the operating room with active bleeding going on. The area is going to be dry as far as bleeding. But unfortunately, sometimes, for example, an artery will be in spasm and won't be bleeding at the end of the procedure. You close it up, they go through recovery, they get home. Later on, that artery relaxes and it bleeds, filling the pocket up with blood. That's usually not a drastic emergency, but if there's a pocket that fills with blood, it needs to be drained. That means another trip back to surgery to drain that, control any bleeding point, and to try to ensure that that's not going to come back, that it's not going to happen again. A lot of patients are really concerned about nipple sensation. Here's the thing about nipple sensation. There are changes in nipple sensation, I think, less than 3% of the time with breast augmentation. Most often, I think it's the pressure of the implant out against the nerves, and fortunately, a lot of the patients who have some loss of sensation find that it's temporary. It's like your foot going to sleep if you cross your legs. You know, if you uncross it, the pressure's off the nerve, the foot wakes back up. And fortunately, within a year, most patients regain some, at least some, if not all, sensation. But there is permanent loss in a percentage of patients, and if that is an issue that really, really concerns you, we'll talk about it more during your consultation. The incidence of deflation or rupture is smaller now than it's been in the past, but it's still there. These are man-made products, and we know that even Michelins have blowouts now and then, and so over time there can be fatigue of the material, and there can be a disruption of the implant. Now, if a saline implant develops a defect in the implant, frankly, it's like sticking a needle in a balloon. It pretty much goes down. Pop, it's gone and people wake up the next morning and go to the bathroom and find their breast is gone. With a gel implant, because the gel is cohesive, and I'll show you that in the consultation room, the gel doesn't go anywhere. It doesn't leave the pocket because it's cohesive, and I'll explain that to you in more detail. So there's no change in breast shape. And so a lot of women who have a disruption of a gel implant may not even know it until they have a routine mammogram, which can detect a disrupted gel implant 70 to 80% of the time. The patients who have a deflated, not a deflated, but a disrupted gel implant most likely need that implant replaced, and because of some excellent coverage that's included in the price of the implant, that usually is not an issue, and the surgery is much simpler than initial surgery, but probably the implant should be replaced. Displacement and distortion of the implant. Those are usually pocket problems. Pocket problems can mean an implant is sitting too high or too low, can be due to poor tissue elasticity, can be due to muscle spasm that moves the implant upward and the pocket heals a little bit high. In some cases, after a period of time, if there's still some asymmetry and there's a pocket distortion, some patients are taken back to surgery to have a revision. And that goes, all of these things go into that 10% overall revision rate. Scarring of the incision is very unusual. I can't frankly remember the last time I did a scar revision on a scar from a breast augmentation. That area does not seem to form keloids. It doesn't seem to heal poorly. And so from a breast augmentation alone, I've not really had a significant problem with scarring, and it's really not been an issue in my practice. A lot of girls, especially young girls, are interested in knowing about stretch marks. Stretch marks are extremely aggravating to people, and I think what I find in my practice is the really young patients who have not had babies are the ones that seem to develop the stretch marks more. My personal opinion is the same girls who form stretch marks with a breast augmentation are the same ones who would, with pregnancy, also form stretch marks. It's a genetic thing. It has to do with the elasticity of the tissue and to some degree the size of the implant that goes in there, but I don't see it very often, and it has not been a deterrent in my practice. Like all surgery, there can be swelling and bruising. Now, swelling's a normal thing when you manipulate tissue. Bruising just means there's some blood out in the tissue. That's different than a collection of blood in the pocket. Bruising does not require any treatment. It is not really a significant issue. It just takes time to go away. A pneumothorax means a collapsed lung. That is something that really gets people's attention. I'll tell you that in 30 years I've not had one. I'm going to knock on wood. I've not had one, and I don't intend to have one. You never know. I know what to do if I have one, but I've done so many breast surgeries that I know how to dissect the pocket and not get into the chest wall. But that is a possibility. It could happen. If it did happen, it would be taken care of immediately. Patients occasionally ask me about rejection of an implant or extrusion of an implant. And I can honestly say that in over 4,000 breast surgeries with implants, I have only seen perhaps one patient that I feel rejected an implant. I am not sure it was a reaction of some sort. I just don't know if her tissues accepted the implant. But 1 in 4,000 or 4,500 is not a very high number, and I don't think that generally that's a significant issue to talk about. Breastfeeding is an issue that's important to a lot of people. Some of my patients come in and they've already had babies and they've already either tried to breastfeed or they've breastfed. So they have a track record about their ability to breastfeed. If you ask your OBGYN doctor or pediatrician or whatever, you'll learn that at least 25%, if not higher, of patients who want to breastfeed, have a child, for one reason or another cannot breastfeed. If the patient's never had a baby and they have a breast augmentation, then sometimes they assume that their inability to breastfeed is due to the surgery, when in fact they are probably in that category where they could not have breastfed anyway. So I think if you could have breastfed anyway, you probably still can, especially if you have the incision under the fold of the breast and you're not doing any surgery on the ducts and the glands, the nerves that are related to breastfeeding. Breast cancer and mammography are both huge, huge topics. 1 in 8 women across the board will get breast cancer. It seems to be getting more common, or at least we hear about it more. It's something that's extremely scary. And if you really think about the number of women that I do breast surgery on, and I think 1 in 8 of those women will sometime in their lifetime have breast cancer, it's a scary proposition. What we know is that if you catch a breast cancer early, it's curable. There is a lot of debate and there's been a lot of change on the recommendations for mammography. And even very recently to this video, in late 2015, there's been a change in the American Cancer Society in terms of what they're recommending for mammography. The American College of Radiology has a different guideline. So there are 3 different guidelines and opinions about what is the timing for mammography. If you have no primary relative, and that means not a mother or a sister who's had breast cancer, I follow the American College of Radiology guidelines that you start getting mammograms at age 40. If you have a primary relative, then you're probably already getting mammograms because your risk of breast cancer is much higher. So at this point, I will follow that guideline. It could change as more information comes out, but from this point right now, we're requiring mammography preoperatively on all patients 40 and above, as long as they don't have a primary relative who's had breast cancer. And I'm going to follow up something I said a minute ago. Breasts are not twins, they're sisters. Your breasts are never going to be identical twins. They're going to be sisters. There's always going to be some differences that I'll point out preoperatively and I'll point out postoperatively. So while your goal and my goal is the same, I think reality is no breasts are exactly the same from side to side. The next big category that everybody really wants to know about is the financial aspect of breast augmentation or any procedure they're about to have. And so there's several options that you have and several decisions you make, whether you pay in cash or you finance it. Now, if you finance it, we use companies that finance cosmetic surgery, like Care Credit, which is a branch of General Electric. It's a large company. They do that basically as a large business, and your interest rates will depend on your credit rating, and you can get financing for up to 5 years for a fairly large amount of money to cover your surgery. Sometimes you'll get a better interest rate at credit unions or banks, and we recommend that if you're going to finance your surgery, that you finance it with the least amount of overall debt and interest rate that you can find. Included in the price that you'll be quoted for your surgery today will be a fully accredited surgery center, a certified anesthesia provider who will be doing the anesthesia, the procedure itself, the implants, follow-up visits, and what I call a 2-week global. Now, what I mean by that is anything that you need that you go back to the operating room for within 2 weeks of your surgery is included in the price of your original surgery. Now, I would challenge you to ask your local hospital if they'll do the same if you go there and have surgery. And then if you have a complication and go back, you know how that goes. You're going to be charged for everything you do. But we think it's very fair for our patients that we give them 2 weeks, and if they have some of the things, more common things that we have to go back for early, like a collection of blood, there's no additional charge for that. On the other hand, if it's after 2 weeks, if it's something that is out of the control of the initial surgery or the surgeon, if it's something, for example, where your body has formed abnormal scar around an implant, or you develop a very late infection, which is unusual, or for whatever reason, there are additional charges. And those charges will cover surgery center cost. It'll cover the cost of me having the certified anesthesia provider come in to give anesthesia. That will generally run anywhere from $1,200 to $1,400 to cover those overhead items. Additional to that will be any implants and materials that we might use, and a surgeon's fee, which may very well be discounted. It's really real important that you understand that your procedure cost is what most likely you'll pay, but because there's a 10% revision rate, there may be other costs, there may be other charges that you don't anticipate. And I understand that that's an aggravation, but I think it's also important you understand that there could be additional charges to you. What to expect? I think as you're looking to doing this, it's important to know what to expect. Before the day of surgery, you'll have some minimal lab results back to us to make sure you're not anemic and so forth. You'll be given prescription for some antibiotics, and you'll do a scrub to your body the day before surgery and the day of surgery before you come in for surgery. The day of surgery, you come in an hour or a little bit more before your surgery, and you're given some oral sedation, which is something pretty mild, but it makes everything calm and makes getting the IV started easier. You'll get an IV started. You'll be given about 30 minutes before your surgery, you'll be given some IV antibiotics, so you have antibiotics in your system. And you'll be marked surgery in a room we call the holding room. And so we'll make marks for the pocket location, for the incision location. We'll make any final decisions about adjustments or sizes and so forth at that time. The procedure itself then, once you go to the operating room, runs from about an hour plus or minus 15 or 20 minutes. Now, some of them obviously go faster than others. Some women ooze more, a little bit more than others, and you have to spend more time controlling bleeding. But about an hour covers most patients. The sutures I use in most patients are under the skin. You have no sutures on top of the skin that need removal. So the sutures are under the skin. They're long-lasting to hold the wound together until you get a good scar. And the only thing on top of the skin are little tapes we call stair strips to reinforce the skin part. Then in the recovery room, you are waking up. You're placed in a bra and usually an elastic strap over the top of the breast to keep the implants in the pocket where they need to be. And most patients are home in an hour or two. The local anesthesia that you receive at the beginning of your surgery, but after you're snoozing, lasts several hours. So that does not wear off usually until late afternoon or way into the evening. At that point, any pain you have is treated with oral pain medication. The only other thing you get is antibiotics. So there's not a lot of home care per se that you need with breast augmentation. You can eat a regular diet, eat whatever you want. You can be up and about. There are not restrictions. We don't want you working out or doing any real exercise to the chest muscles. But on the other hand, we have some patients that go out to eat or go shopping the night of surgery. Just depends on your pain threshold, how you do, how you perceive it, and so forth. but we see a wide variety of how patients respond after the surgery. Our routine follow-up after breast augmentation is we see patients at 1 day, at 1 week, at 1 month, at 3 months, and then after that, or in between, as needed. By about 3 months, most patients are stretched out, and I'll explain that in a second, and get close to their final result. We like people to wait about 6 weeks before they engage in heavy exercise, particularly to the upper body. By then, everything's healed and you're not likely to stir up trouble. Keep in mind that your final result is not going to be there, and you're going to get a pop quiz on this, by the way. Your final result's not going to be there for 8 to 12 weeks after your surgery. We're going to place a foreign object under your muscle tissue. It's under the fatty tissue on top of that, and skin, and all of that tissue has to relax and accommodate that new volume. And so it's not something you'll see a final result on in a week or 2 or 4. It's something that takes 8 to 12 weeks to get your final result. The next category is droopy breast. The medical term for that is ptosis. It's P-T-O-S-I-S. And droopy breast can be either developmental or acquired. There are some girls who, when they hit puberty, the breasts don't develop in perky, nice, rounded breasts, but in fact, as they develop, they develop in a more tubular shape or a droopier shape and so forth. And you see a wide variety of breast shapes and sizes. And so it can be purely developmental, and a lot of patients I see have never had perky breasts. Other patients develop droopiness after childbirth, particularly after multiple children with breastfeeding, after a lot of weight gain, weight loss, and so forth. Over the last several years, there have been significant changes in the surgical approach to breast lifting, and they're important for you to know. A lot of the people trained in breast lifts prior to the last few years were trained to use basically a skin brassiere to hold the breast up. And so there was a pattern of skin removed from the breast. The nipple was pushed upward. The skin was closed in hopes that the skin would hold the breast up. And frankly, there's still a lot of surgeons out there who use that skin brassiere type approach and get results that are less than optimal. And the reason is simple. Skin stretches. If you've ever been pregnant, you know that. You know what happens when skin's under tension. So a lot of these patients would look really good for a month, pretty good at 2 months. By 6 months, they've bottomed out, stretched out, and they're unhappy. So the procedure has been changed substantially to involve the creation internally of breast tissue of support columns, essentially, that hold the breast up. So the skin part now is secondary. It's no longer a primary part of a breast lift. It's secondary. And so by creating the support columns, you're able to get good support to the breast that's long-lasting. The other thing we've known for a long time is when breasts change in an unfavorable manner, it's usually because they bottom out at the lower pole. And so one part of a breast lift now is, and it's very routine, is removing to some degree a crescent of redundant breast tissue at the bottom. So in addition to that, in most cases of mastopexy, there is a lack of upper pole fullness, and that is the one thing that people say is after babies they lose the fullness up here above the nipple. And so using an implant, not a large implant, but using an implant is the way that we're able to get a rounded breast, a more youthful looking breast. When combined with the support columns to hold the breast up, and when combined with removal of a bit of the tissue at the lower pole, we're able to get a much better result in a predictable fashion. And frankly, I've gone in the last 10 or 12 years from not really liking breast lifts very much to, at this point, I like them pretty well because I think they predictably give good results. So it is important to understand that most patients who have a breast lift need implants, but not all. And that's determined sort of jointly between myself and the patient. And if there's enough thickness of tissue above the nipple that we can do a breast lift alone without an implant, then that's what we're going to do. And at the very worst, you can see how it works. And if you don't like it, you can come back in 3 months or 6 months and have an augmentation with implants. So there are a lot of options here, and there's not anything that's totally dictated to patients, but based on a lot of experience, I'll give patients my advice on what I would recommend. Some doctors recommend that you stage breast lifts and implants. In other words, that you do the breast lift first and then come back in 3 months or 6 months and put implants in. I guess that's good for business. It is a safe way to do the procedure when you need implants and a lift. But here's the deal on that. If you stage a breast lift as well as an augmentation, then what's the percentage, what's your chance of having 2 procedures? Well, it's 100%. I mean, you're planning it that way. The overall national average for revision for augmentation with a breast lift at the same time is 25%. And so in my view, I would rather take a 25% chance, as long as I feel it's safe in an individual patient, I'd rather take a 25% chance of a revision, or in other words, a 75% chance that that patient's going to be happy with 1 procedure, than to automatically have them do 2 procedures with more expense, more time off, more recovery, more pain, and all the negative things about having extra surgery. The need for a lift is determined by what you have. And there's a classification of breast lifts. And most people classify breast droopiness into 3 classes. A class 1 droopiness is a droopiness where the nipple, compared to the fold under the breast, the nipple can be down to the fold but not past that fold under the breast. A stage 2 or class 2 droopiness is the nipple is below the fold under the breast. And a stage 3, class 3, is basically the nipples are looking at the floor. They're on the lower pole of the breast. The treatment in most class 1 droopiness is a breast augmentation, because that will in many cases give the breast an upward-outward boost, and patients can get a very nice appearance with an augmentation alone without doing any lifting. The treatment for a class 2 and 3 is not an augmentation. Those patients, to get an optimal result, really need to have some sort of a lift. Now, that can be as simple as wanting to reposition the nipple to a higher level and just doing an augmentation. And for example, that might involve what's called a crescent nipple lift. A nipple lift is simply doing a procedure that brings the nipple up not quite an inch to center the nipple more in the center of the breast mound, along with an augmentation. That only works in some class 1 droopiness. You cannot hang the weight of a breast on a crescent nipple lift. So it is not a breast lift, it's a nipple lift. And all it does is to center the nipple over the breast mound to get a more pleasing effect. And if you're in that category, I'll show you pictures of that and explain it in a lot more detail. The other breast lifts involve either what's called a vertical lift or a full anchor type lift. And there are variations in between. But what you have determines on the type lift that you might need and what you might end up with. We'll show you pictures of scars resulting from lifting so that you can decide if that's worth it to you and so forth. But in this practice, one thing that I will never offer, and this I've learned this from experience, is I will never offer someone who has substantial droopiness, for example, a stage 2 or 3, a breast augmentation alone. Because if it's not what the patient needs, I'm not going to do it, and I can refer you to other doctors that will do that, but I won't do that because it's not good medicine and it's not something that's going to happen. The risk of an augmentation with a breast lift are very similar to the risk involved that you heard earlier with breast augmentation alone. The risk of sensory change is slightly higher because you're doing more surgery. The risk of skin and nipple loss is there. Now, that is a risk in all surgeries where you're closing things under tension. Whether it be a breast lift or facelift or tummy tuck, there's always some risk of skin loss. It is seen much, much more often. In fact, 17 times more often in smokers. Smoking is not an issue in my mind in terms of the result for the most part in breast augmentation. However, when you are closing tissue tightly like a breast lift, it's a big deal. The patients who are interested enough to have a breast lift and want to improve their shape need to know they need to be off all forms of nicotine for 6 weeks before their surgery. Now, prior to the development of good testing, we couldn't monitor that. And so I'd tell people you need to be off for a year, and a lot of those patients would just go away and I'd never see them because they knew they couldn't quit smoking for a year. What we do is, when the patient knows when they want their surgery, they have a preoperative conference scheduled 3 weeks before their surgery. What we do know is that the nicotine testing that we use will pick up for 3 weeks. If you have one cigarette in 3 weeks, it'll turn it positive. So at 3 weeks before your surgery, we do a test on you. And if that test is positive, we cancel your surgery. I won't do the surgery if there's nicotine in your system. If it's negative and you've quit smoking, then the day of surgery, we do another nicotine test to make sure that you've not slipped in the meanwhile. Because what I want is that 6-week period that cuts the complication rate by about 80 to 85%. Then there have been cases where I have canceled surgery the day of surgery in those patients who thought they could get away with smoking, and on the day of surgery we've canceled surgery because they've tested positive for nicotine. The question about breastfeeding after breast lift comes up occasionally, and I think the answer is similar to doing a breast augmentation, but there is more surgery done to the gland, so I think probably there is a little bit higher risk to breastfeeding with a breast lift than with breast augmentation alone, and I think you have to take that into consideration. Now, as we get close to closing, I will tell you that there's no way that once you get a result that you really like, that I can freeze dry that and keep it there forever. There are going to be changes over time. Everybody knows that as you increase your age, your elasticity of your whole body decreases. You know what happens. You can look at your mother and your grandmother and you just see changes. That stuff happens. Same thing happens in the breast. The breast will relax with time. Now, it's unlikely they're going to relax enough to where they're awful looking and you need more surgery. But it could happen, but it's very unusual, and I've been doing this a long time. I've not had to do revision mastopexy very often for that reason. More pregnancies can affect your breast. You know, if you've ever had a baby, you know in the first place, if you need a lift and you've had a baby, you know that going through 40 weeks of pregnancy and having a baby has an effect on your breast. So if you have more, there's no reason to think it won't have more effect on your breast. Again, I don't have to redo lifts very often. In fact, it's very rare on people for that reason either. Weight gain and weight loss are another reasons. I think a lot of times it gets down to genetics. What sort of elasticity have you inherited from your mother, your dad, your ancestors? Because that determines the strength of your tissue and how they're going to hold up. As I mentioned earlier in the video, this is purely a cosmetic procedure. It is not like a ruptured appendix or a blocked heart artery that needs immediate medical treatment. These are procedures that you can choose to do that if you don't do, won't change how long you live or anything else. It's done for appearance. So I've always felt that the primary alternative to doing breast augmentation or any cosmetic surgery is just simply don't do it. Now, if there are other alternatives in terms of procedures, then I'll talk about those with you during your consultation. That'll be based on your anatomy and what we see and so forth. The last thing I want you to do is, now that you've gotten to the end of the checklist and you've initialed all of these, or at least you've written questions down, the last thing I'd like for you to do is you'll read that there's a statement that you've read what essentially are my education, training, board certifications, and so forth. There'll be a document in the room with you that you'll have with you that'll probably all be on the clipboard. I want you to read that and initial that you understand that. I want you to know what my background and training is. You've already heard my experience, but it's important that you document that you understand that. Now, then, as we close, please, at this point, make sure that questions you have are written at the bottom of the form, and I'll make sure that when you walk out of this office, that all of your questions have been answered. I'm sorry this has taken so much of your time, but I hope it's been educational to you. I think we've covered most of the things you need to know as you consider breast augmentation.